Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare delivery and technology. I'm really excited today. My guest is Darlene Turner. Darlene is a healthcare provider and well known for her advocacy in women's healthcare and to underserved populations. She's an author, an educator, and a policy expert in these areas. I've been wanting to speak with Darlene for some time and glad she is able to be with us today. Darlene, welcome to the show.
Hey, Jim. How are you?
I'm doing fine. Let's just jump right into it, Darlene.
Okay.
Recently, I've become aware of your leadership in a project related to healthcare technology that is meant to address some of the challenges and barriers in healthcare. I look forward to hearing details about that, but first let's start with the basics.
Okay.
What led you into healthcare, Darlene?
Oh my gosh. I have been interested in women's health and, women's reproductive health in particular since I was like 12, when I was sitting in my mom's kitchen in July of 1978. And this is CBS Evening News with Walter Cronkite. And today we're reporting that Steptoe and Edwards report the birth of the first test tube baby. And just my little 12-year-old mind was like, what? You squished a baby in a test tube? And so began, how I got into women's health care, women's health research, women's health advocacy and policy.
Well, that is certainly the birth of it. No pun intended there. But, I know you went to Duke to their physician assistant program.
Yep.
And so did that passion for women's health and women's reproductive health, is that the reason why you went to PA school, or was it just healthcare in general?
Well, I started out, as an undergraduate, I thought I was going to go to medical school. And I got into undergraduate school and went, no, that's really not what I wanted to do. I considered midwifery school. And when I saw Duke, I was like, okay, that's what I really wanted to do. And I appreciate my education at Duke, but when I look at it, that really wasn't it. And at the time, what I really wanted to do and loved doing and what I'm doing now is more public health. And, it's interesting that you ask, how did you get into what you want to do? And it really has been a kind of trial and everything. I've tried a lot of different things and kind of have landed. But I think, just to throw this in because I'm thinking about it, having a daughter now who is a senior in high school and trying to figure it out, it is so hard at that age. Like I knew what I wanted to do, but I didn't have the correct verbiage and understanding of healthcare to get where I wanted to go. So it's taken me some time, but really being on that public health, community health front is where I've wanted to be, because I've always kind of noticed this lack of attention to the emotional side of women's health, to what a woman's going through, what are the things that are impacting, and what are the intersections of the varying aspects of her life. And that is what I'm doing now. That is what I'm really passionate about. But I didn't have the verbiage then, or the knowledge even, that such a thing existed. So it's been a journey, but I'm pretty happy where I've landed.
Well, I know I've read some of the things you've written as an author, and you are an educator and certainly involved in policy in this area. Are you still directly involved in the delivery of healthcare, midwifery, doulas?
I am. I just witnessed the birth of a little guy Tuesday morning, 5:52 a.m. Central Time. So, yeah, still very much involved in supporting moms. But what I am really trying to move into now is really kind of restructuring how we do women's health, in that, we focus so much on, like, I hear so much, we need more healthcare workers. We got to train more doctors and nurses. And I know I'm going to make some enemies here, but we really don't. Because what I have learned in the work that I am doing is I can support a mom. I could support a mom back to back to back. I could do births all week. But if we are not addressing the social determinants of health, if we are not addressing the other aspects of a woman's health, no matter how great care delivery is in the hospital or at the birth, we're still going to have poor outcomes. And so while I love doing births and things, I'm really working now on training other women to do that work, because I've now come to know that there is an art to supporting women through childbirth. And it really isn't from the actual healthcare aspect. It's from the community, and it is from the ancillary services and the community resources that we need to make sure. We need to make sure people have housing. I mean, if nothing else, COVID has shown us when people don't have housing and people don't have food, clearly their health suffers. It's just a fact. When people don't have employment, when people don't have money, these are the things that I am finding now more than just whether or not a woman can get to the doctor are impacting health outcomes.
The whole concept around that phrase, social determinants of health. 5 years ago, I had never heard that phrase. Maybe it was there, but I'd never heard it. But now I hear it with increasing frequency, that your ability to have access to adequate health care is dependent on your zip code, the color of your skin, the whether you live in a rural or urban. So many different determinants kind of come together.
Absolutely.
And there's the concept that we know that a minority of individuals often need the majority of healthcare.
Exactly.
And whether it's a disease-driven thing, diabetic, or they're in a income area that's lower, or whatever you want to call it. And so that whole concept of social determinants has been really a foundational aspect of public health. And it seems to be a lot of research and hopefully action going into that whole area.
Well, I mean, I think, and as the more I look at this, the more I realize it's a really easy fix. I mean, we just watched in this country our Congress fight over whether or not to give people $600 or $200 checks for support during COVID, and basically get it shot down. Now, there are a whole myriad of arguments with that I'm not going to get into. But what I think people do not understand is, if for a lot of people, $2,000 would not be enough to cover all their major expenses. But if you can keep a roof over your head, or that can contribute to that in a significant way, there's a lot to be said for not being outdoors in the dead of winter, and the food aspects we've had. I'm down here in Texas, and we've had just monster food lines down here. And you're not thinking about going to the doctor if you're hungry. You're not thinking about going to the doctor if you're cold and tired and worried about being mugged during the night. So, if we are not addressing people's creature needs, as I call them, you can't get people to do these sort of other health enhancing measures when their basic creature needs are not being met.
Just as you're speaking about that, Darlene, I think that's one level, the basic creature needs. Also, access to technology. When COVID hit and the schools had to empty, there were some groups that had broadband internet and laptop computers all over the house, and others that didn't have it at all. Just being able to have access to the internet or not has healthcare ramifications, it seems like.
Exactly. This is something that's been a huge issue of conversation here in Austin, because, Austin's very high tech, and, everybody's like, oh, Austin's so great. It's so innovative. All these major tech companies are moving here. But what a lot of people don't know is that a very large population, a large percentage of our population lives in poverty. And so when we're talking about the school systems and things, there are roughly 65% of the kids who are living in poverty, and they don't have internet at home. One thing I will say is a lot of the tech companies and other philanthropists and such contributed to increase broadband or get people hotspots. And then the school district provided Chromebooks to the children. But I mean, it was really, I knew because I've taught in the school systems, but a lot of people were just shocked, like, oh, they don't have internet at home. And I'm like, well, migrant workers aren't online necessarily. And, we have to really think about who are we serving and what are their needs, not what you think their needs should be. And that is an argument and a battle that I wage daily here in Austin with my colleagues because, the large healthcare systems and the, training facilities, the medical, I'm thinking of UT and what do you call it, the training hospitals and things. They're like, well, it should be this, this, and this. And we're like, but people don't have that. Yes. And that is where the disconnect is because, people say, well, we'll do telemedicine. I said, on what? A lot of people, yes, they have a cell phone, but it's a flip phone. So, okay, you can do a phone call, but you can't do a Zoom call. And if they're trying to show you, I have this thing on my arm and they only have a flip phone and they can't take a picture, they can't do Zoom, where are we? Yeah.
Well, that leads us into the doorway into healthcare technology. I'm aware you're involved in the development of a software platform that, as far as I can understand from what I've heard about it, Darlene, it is to allow communication and data, which I guess is a form of communication between providers, patients, and possibly some way with interoperability or data liquidity to provide some of that information to a hospital if somebody presents there. And then on the back end, you can capture all that data and use it for data analytics. So, but of that, I guess, three legs of the stool there, one of the stool legs may only have a flip phone. So as you are approaching and involved with this development of this software platform, you're having to take that into account, really the lowest common denominator. So tell me a little bit about what you want this software platform to do and why you decided it's needed for the kind of work you're involved in.
Well, I run, one of the things I do is I run or have established a community-based doula project in which we train primarily low-income women of color from our under-resourced and rural communities here in Texas to provide ancillary maternity care services. So we're doing prenatal support, childbirth education, birth planning, continuous labor and delivery support while the mom is in labor, and then home visits and support for up to a year postpartum, up to the baby's first birthday. And we have battled back and forth with Medicaid to be able to be reimbursed. And their first argument was, well, we have no idea. Doulas are an unregulated profession. We don't know what you know. So I got funding in 2019 and did a small pilot cohort of women that I taught. And in the course of teaching and training and getting them certified, I also developed a very specific curriculum to be able to say, this is what they know, this is the training, this is the number of hours, that whole thing. And so that's actually come back to be a good thing because now they're like, oh, okay, because my doulas end up with about 200 hours of training. That's fairly significant because I think a lot of people thought, oh, well, they just go in and they kind of pat the mother on the hand. Oh, okay, that's fine. And it's no, we're doing home visits. We're doing some case management. We're helping them get to the food pantries. We're helping them get to places that can give them rent support. So we do there are a lot of different facets to what we do, but also trying to coordinate what a mom needs with the resources, keeping track of it all. We have not had a good data management system. Doing it by hand was quickly dispensed with. The paperwork and making sure that those records are kept private was like prohibitive. We're currently using a software system that we can kind of keep track, but there's not really the interface between the moms and the doulas. And that's been problematic. So doulas are fine, she can text me, but it's like I keep saying to them, you have to then take that text thread and drop it in so that we have that record, and we haven't had that. Then, I've like just this past week when I did that birth, mom's like, well, can you bring a copy of my birth plan? Which I was happy to do. It wasn't a problem. But if we had had that integrated in our software, she could have had a copy on her phone. I would have had a copy on my phone. I would have also had a copy in our back end of the data system. And, we could have just kind of shot that forward or brought it with us. And, she could have allowed the nurse to airdrop it or even emailed it to the nurse coordinator on the unit, and they could have just printed it off. So we have these different levels of trying to coordinate care and have things. I have a mom now who's pregnant with twins, has history of incompetent cervix. So she's seeing a maternal fetal medicine physician. She's seeing her OB. She's working with me. There are things she's telling me that I know she's not telling them. And it's not so much that I want to spill the beans on her, but there are certain aspects that I know if they knew and understood that we would be better covering her care. And there are things that she's not even thinking about, but she's telling me I'm dropping into my notes that, are going to have impact on her care down the road. So what we're trying to do with this software is have it interactive so that whatever the mom tells us gets dropped in, whatever we tell her or any, handouts or whatever, we go back and forth. But we also have the ability to kind of compile notes or reports that she can then hand off to her doctors, because we're trying to keep the whole HIPAA thing. We have our end, HIPAA compliant. But then also at the end of the day, because we're setting up doula projects, working on setting them up around Texas, that I can go, okay, what's going on in our project in West Texas? And look in and kind of put in, for example, if we had someone in Lubbock, we don't have anyone there, but this is just an example. If we had a unit in Lubbock, type in Lubbock and see what the doulas there are doing. What's the patient load? What are the trends, say, for Lubbock versus here in Austin versus in Beaumont? So to be able to look back and forth, and then that way, as I'm now speaking with the Department of State Health Services, and we're trying to streamline what Medicaid is going to do. Like they don't do this, which I'm flabbergasted at. But we can now say, okay, or we will be able to say once we get this all up and going, okay, this is our baseline, but we find that moms in Lubbock or doulas and moms in Lubbock need this. We need to add more resources and funds for that over in Lubbock versus we don't need that as much in Beaumont. So let's not have that over there. And then we need this up in Waco. And then we need this down in Brownsville. And that way, I think we're going to have better utilization of our Medicaid resources.
Darlene, a couple of things there come to my mind. On the back end, as this data is gathered, it sounds like the data analysis, from what you've told me, is being done to come up with best practices and lessons learned about the really best return on investment as to where things need to be offered. But then also you have a need to prove in some way that this program lowers the cost of healthcare, basically,
Exactly.
The bottom line.
Well, it lowers the cost of healthcare and it improves outcomes, because the report that I'm preparing right this as we speak for the pilot grant that we got, I've been able to demonstrate it. And it's hard to say because we had such a small number of women, but if we can extrapolate out the numbers that we got, like we had a 95% start rate for breastfeeding in Black women, which in the country nationwide is only like 60%. We had like 75%, or no, we had like 83%, because I don't have this in front of me, 83% vaginal births, full-term vaginal births. And we know rates of preterm births in Black women is like through the roof around this country. We know that Black women are 3 to 4 times more likely to die in childbirth, and even more likely to have what we call near misses, like catastrophic complications during pregnancy, labor, and delivery. That everybody's like, well, what is it? It's access to care. No, it's all these other social determinants, but also having a support system. Many of the women that I work with have moved to Austin for, for jobs, for work, whatever. They don't have family around. So when something comes up, they have no backup. If mom gets sick and she has a toddler at home, like if she starts bleeding and she has a toddler at home, not only is she trying to get herself to the hospital, she's also got to contend with, her toddler. We get to the hospital and they're like, well, we can't have the toddler here. And she's like, well, I can't leave my toddler at home. It becomes a CPS situation. I mean, it becomes just this catastrophic thing, which is not helping her health, because in the course of her potentially bleeding with this other pregnancy, she's worrying about the child that she has. The hospital staff is saying they can't have the child there. She had no one to leave the child with. And I mean, this is literally a situation I dealt with.
Sure.
So, as doulas, as community health workers, and it's a combination of what we've done, we're identifying these women, and we're also within Austin and Central Texas and then in other places setting up resources like, if this mother has this happen, who are we going to have come right away and take care of her child so that she can get to the hospital, get the care that she needs, know that her child is being taken care of. And, but these are things like the healthcare system has no clue, and we see on the day-to-day basis. But again, when we would intake her with this software, she would put in, potentially, I'm a single mom on my own and I have a toddler and now I'm pregnant, so that we can have that in our mind, like, oh, when she goes to deliver, we need to have someone with her toddler, who, and an organization or a collaborative, I guess you would call us, of doulas here in Austin. We started something with this and we got a grant to be able to set up an emergency child care system, for lack of a better word. But again, that would be something that would be in my database, like, okay, she's going to need access to the emergency child care system. So I'm shooting that over to them that, hey, I have this mom, I want her on the roster, so that we know the minute we get a call from her, someone's heading out to her house, we get it all set up. She gets to, put the things that are important to her, so that the provider that comes to her place, that's already a done deal. But these are the things that having, a data system can help us identify and help us be on the front end of things, so that they're not scrambling. I mean, last year alone, I had 2 mothers take an ambulance to the hospital because they didn't have a ride to get there. Mm-hmm. And, we've argued with Medicaid, can we get rides? Well, they have to call 72 hours in advance. Well, she wasn't in labor 72 hours before. Well, she should take an Uber. She doesn't have money. Yeah. So these are the things that we're going to put in, that our data management system will have this information on the mom, so that we can be on the back end working on, because there are transportation systems, ancillary transportation systems. Yeah. But if we don't know, we can't get her set up.
This is fascinating, Darlene, because we know in traditional electronic health record systems, there's clinical decision support, rules and alerts. So if you have high blood pressure or hypertension as a diagnosis, and somebody takes your blood pressure and records it, if it's high, there's an alert. What you're talking about is having that for social determinants. If we know a phone call goes in, somebody is beginning labor, these things that need to be put in place, there's an automatic kind of notification. I can't believe it, Darlene. We're almost out of time here. But before we run out of time, I know a lot of people are interested in contacting you and finding out more about your work. So how can folks find you online, email? What's the best way to find out about Darlene Turner and the work she's doing?
Well, I have 3 or 4 different platforms. I would say, especially as it pertains to this software, I'm really working on that through our community-based doula project, and that's the Healing Hands Community Doula Project. We're down here in Austin, Texas. The website is www.blackdoulasblackmamas.org.
We'll put those links on the website.
I'll give you the link. And then the email is admin@blackdoulasblackmamas.org. And it comes to me. It'll dump to me.
Okay.
And that's fine. Yeah. That's the best way.
Okay, great. And we'll publish these so folks can reach out to you directly.
Yeah.
To our audience, let me say thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Darlene Turner. Darlene, thanks so much for coming aboard today.
Oh, thanks, Jim. Thanks for having me and letting me, share, because I just want to say thanks because I don't think people understand, like, there's so many other things, so many other factors that are impacting health that in a lot of ways people would think have nothing to do with health, but they're huge impacts. So if people can just start thinking about that, and for us, we're going to try and compile all this data and get it going.
Darlene, I wish we could clone you. We need a lot more Darlene Turners out there. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.